Hello, everyone. I'm Dr. Richard Childs, and I'll be discussing CAR T cell therapy and hematopoietic stem cell transplantation, giving updates on the current status and future directions of these procedures. So we'll first go over CAR T cells and how they work. To generate CAR T cells, blood is taken from the patient that has cancer. Those cells are then cultured, isolated, and genetically manipulated to be reprogrammed and to express receptors so that they can recognize target antigens expressed on the cancer cells. They're grown outside the body and then infused back into patients. And then those cells are alive, they proliferate, and they can hopefully go to the target the cancer and destroy the cancer. So if we drill down a little bit more specifically in terms of step-by-step on how CAR T cell therapy ultimately ends up as a therapeutic for the patient. The patient undergoes a procedure called apheresis, where IVs are placed in the patient or a central line is placed, blood is withdrawn, and then those cells that specifically contain the T cells are isolated, and those cells are stimulated outside of the body or activated. They're exposed to a vector, often a viral vector, to insert a gene that encodes for that specific receptor, recognizing something that's unique to the tumor and hopefully expressed in all the tumor cells. Once those cells are genetically reprogrammed, they're expanded usually somewhere between 6 to 10 days outside of the body. They're then cryopreserved. Patients then are ready to receive that therapy. They get some chemotherapy to knock their white cell count down so that these genetically manipulated cells will not have to compete with the patient's own white cells, and then they're infused into the patient and will home to the tumor and then mediate an anti-tumor effect. Now, one of the most popular types of CAR T cells targets an antigen called CD19. This is an antigen that's expressed on the majority of malignancies that arise from the B cell lineage. This includes cancers like lymphomas, large cell lymphoma, mantle cell lymphoma, and includes some leukemias like B cell leukemia, acute lymphoblastic leukemia. In this case, the T cells that contain the CAR have a receptor, single chain variable fragments that are able to bind to that CD19 expressed on the malignant cell, and they're able to kill it. This CD19 being expressed only on B cell lineage and not on any other normal tissues is one of the reasons that these CAR T cells are so powerful. They attack the malignancy, and then the only other normal tissue they would attack would be the B cells. So we often do see B cells in the patients eradicated as a consequence of CD19 CAR T cell therapy. But despite these cells being eradicated, you can do perfectly fine. So CD19 CAR T cells have now been approved for a number of different uses. They're unlike chemotherapy, where you get one dose and then you have to repeat that dose because the effects are short-lasting. These cells persist and survive in the patient's body potentially for a lifetime. This was one of the original studies that was published in the New England Journal, reporting that in adults and children with B cell lymphoblastic leukemia, the complete remission rates of 81% could be achieved, with event-free survival rates being at 6 months, 73%, at 12 months, 50%. And these were primarily patients that had refractory disease. And you can see here, overall survival of these patients and event-free survival. So there certainly are patients that are relapsing within the first year. But the question now is, if you get out more than a year or so, can you actually cure patients with these? And only time will tell, but we certainly do have some patients that have long-term event-free survival, raising the hope that this therapy may be curative for some patients. More recently, there has been data that CAR T cells targeting a protein called BCMA that's expressed on myeloma cells can also be effective as a therapeutic for multiple myeloma. In this trial, patients had to have very heavily treated myeloma, had failed a median prior 6 lines of therapy. When they analyzed these myeloma cells, they found almost every single myeloma cell express this BCMA antigen. And this is the data from that trial that was published this year, showing patients receiving these CAR T cells at various dose levels, where you can see the overall response rate was remarkably high. Refractory myeloma, 73% of the patients showed evidence for a response, including remarkably 33% of the patients overall having a complete response, 26% of patients becoming MRD negative. So, I mean, this is a huge advance for myeloma. This kind of therapy, you have to keep in mind, is being used in patients with very advanced and refractory disease and still has a very high response rate. And that's led to a number of trials now bringing this therapeutic up earlier to see if the response rate will be even higher in patients with less advanced disease. The major complication of this therapy is something called CRS, or cytokine release syndrome, and we'll go through that in a minute. 84% of patients have experienced some form of cytokine release syndrome, but only 5% of patients have had the grade 3 cytokine release syndrome, the more severe. So most of the cytokine release syndrome is mild to moderate and easily manageable. This is a list of a number of FDA-approved CAR T-cell products made by a variety of different companies. You can see that the first 4 listed here are all targeting CD19 with an approval for ALL and adults with large B-cell lymphoma, mantle cell lymphoma with the Tecartus product, and then the Epsema, which I just mentioned, which targets BCMA, approved for patients with myeloma that have failed at least 4 lines of therapy. As I mentioned before, this is a living drug that stays in your body potentially for a lifetime. So we will see patients that have short-term survival where we may take them on to something more definitively known to cure them, such as an allogeneic stem cell transplant. But there's also patients that are not transplant candidates where we have increasing data that as they grow up, that they may ultimately be cured with this kind of therapy. And here you see this young woman going from 1 year to 8 years and remaining disease-free. So what are the challenges with this type of therapy? Well, you have to produce it, so you have to collect the cells and send them out to the production facility. Sometimes you can't collect enough cells. The patient may have received a lot of chemotherapy and you can't generate them. That's a problem. Sometimes the cancer can lose that target antigen and become bald, basically, and escape these genetically modified cells. There can be toxicity with CAR T cells, including cytokine release syndrome. There can be neurotoxicity with these cells as well. And then probably most importantly is that we have lots of cancers that we don't have CAR T cells for, that there's a big unmet need to try to use this type of advanced therapeutic, particularly for solid tumors. Just closing, cytokine release syndrome can involve a number of different organs. It's where these cells that we put in begin to proliferate as they encounter the tumor antigen, and they release all kinds of hormones that we call cytokines. This can lead to feelings of severe fatigue, can lead to fevers, chills, low blood pressure, can affect multiple different organs listed here, including the brain. When we grade this based on severity, it's often based on whether the patient has organ symptoms such as lung problems, hypoxia, or problems with their blood pressure. For patients that just have mild reductions in their blood pressure or a mild oxygen requirement, we'll often just manage them with supportive care, some oxygen or some IV fluids. If it becomes more severe, where the patient has severe low blood pressure or severe hypoxia, then we'll manage them with aggressive support in the intensive care unit. And we can give a drug that targets one of these cytokines that is released commonly, IL-6. This tocilizumab is FDA approved for that and can turn patients around literally in a couple of hours after administration. So that's all I have for CAR T cells. We'll move now and talk about allogeneic stem cell transplantation. There's 2 types of transplants that we perform: an autologous transplant, where we use the patient's own cells to rescue the marrow. We do a harvesting of stem cells, usually collected by mobilizing stem cells to the circulation with some hormones, plerixafor, G-CSF, sometimes chemotherapy. We collect those intravenous by the vein and we freeze them. We then give the patient high-dose chemotherapy, alkylator agents, a variety of different chemotherapeutic drugs that are active against the cancer, sometimes even radiation. This is intended to try to kill every cancer cell, but in the process of doing that, wipes out the bone marrow. And then we can, after these chemotherapeutics are out of their system, we can thaw down these stem cells and infuse them back into the bloodstream. They'll go back to the bone marrow, and then they'll grow into hematopoietic cells and reconstitute the patient's hematopoietic function. This type of therapy is first-line therapy for patients with multiple myeloma, where it can prolong progression-free survival and overall survival, and second-line therapy for patients with relapsed Hodgkin's disease and some non-Hodgkin's lymphoma, where it can prolong disease-free survival in a number of these diseases. Allogeneic transplantation, we're using stem cells from an allogeneic donor, someone other than the patient. In this case, the patient gets the conditioning regimen, trying to wipe out all of the cancer, and now the stem cells are collected from the donor. It could be a fully matched relative, a partial matched relative, cord blood, or unrelated donor, and then those cells are infused back into the patient to rescue the bone marrow function. Here you can see data on the number of transplants performed annually, more autos than allos, a significant number across the US. And you can see that these transplant numbers are continuing to rise year by year. If we look at indications for transplants, I've already talked to you about the auto transplants being mostly for patients with myeloma, Hodgkin's disease. You can see in blue, the allogeneic transplants are largely used for patients with hematologic malignancies, AML, myelodysplastic syndrome, and ALL being the most common use, and then a smaller use for diseases like aplastic anemia or other diseases like sickle cell anemia. 3 stem cell sources that we can use for allo donors. We can use peripheral blood, where we give these hormones, G-CSF, push those stem cells into the circulation and then collect them. We only take a fraction of what the patient actually has. We can also harvest bone marrow from the donor, from the pelvic bones, or we can collect stem cells from the placenta. This is umbilical cord blood, freeze those cells, and then have an off-the-shelf product. We have about 700,000 of these units available worldwide for patients. So how does allotransplant cure patients? If these red circles here represented malignant cells, the patient is conditioned with the intent to try to wipe out every cancer cell possible, and then gets the allograft infused with stem cells, which also has lymphoid tissue, T cells. And the thing that really distinguishes allotransplants from autotransplants is that these T cells can mop up any residual cancer cells that are left behind, something that we call graft versus leukemia or graft versus tumor, and that can cure the patient through that immune effect. That immune effect you don't get with autotransplants, you only get it with allotransplants. And that's really the powerful part of allotransplantation. This is just to show you graft versus tumor effect in a patient that had a mycosis fungoides tumor that was completely refractory to chemotherapy. A month after transplant, still having these tumors, but we transplanted these immune cells that were able to mediate this graft versus leukemia effect, and you see these tumors now flattening out. And here you see the patient 10 years after transplant in complete remission and almost certainly cured from their disease. 2 types of allotransplants that we do: the conventional high-dose transplant or myeloablative transplant, where we give very high doses of chemotherapy and sometimes radiation, or reduced intensity transplant, where we lower the intensity of the conditioning regimen to try to avoid toxicity, and then we depend more on that transplanted donor's immune system to eradicate the malignancy. The advantage of these low-intensity transplants are that the risk of mortality with the transplant is lower, but the risk of relapse is higher. With the myeloablative transplants, we see that the risk of relapse is lower, but the risk of transplant-related mortality is higher. So it's a trade-off between the two. For younger patients, we still prefer the high-intensity transplants. For older patients, where regimen-related mortality can be significant, we typically use a low-intensity transplant. This just shows you trends from 2000 to 2019 showing you different populations of patients based on age getting an allo transplant. I just really want you to focus on this baby blue up here at the top, and those are the patients 65 years of age and older. We used to do very few of these transplants 20 years ago. Now, using reduced intensity conditioning, roughly a quarter of everybody we transplant is an older patient over the age of 65. So we're able to now bring this curative modality to older patients. Good news with allo transplants are getting much safer. The risk of dying from an allo transplant, if we go back about 20 years ago, has dropped significantly as we've improved this technology and we've gotten better at managing complications. The overall reduction in non-relapse mortality by day 200 is substantial compared to in the conventional era, compared to patients transplanted 20 years ago. So why do we do these transplants if they have a risk that they can harm you with the transplant-related mortality? Well, for some diseases like relapsed AML, ALL, or high-risk MDS, despite advances in therapy, these diseases remain incurable. And allo transplant is the only curative modality for these diseases, as well as a number of non-malignant diseases where allo transplant is the only modality that is a definitive cure. So when do we like to do these transplants? Most of the data would suggest that the earlier you do the transplant, the better. This is AML data showing the probability of survival after a transplant if you're in your first complete remission, second complete remission, or if you have relapse refractory disease. You can see that those patients that get a transplant that are in early stage CR1 or CR2 are the ones that have the highest probability of long-term survival. And if we look at transplant numbers across the US, we see that most transplants in AML now are being done in patients with early disease, particularly CR1, as the relapse rate will be lowest in those patients. What do we need to do a transplant? We need to have a donor. Each sibling has a 25% chance of being HLA identical. So that's a potential donor that we could use. For patients that don't have an HLA matched sibling, roughly we say 20% of patients will have an HLA matched sibling. We can use an unrelated donor that's perfectly matched that we get through the National Marrow Donor Program, or a family member that's a partial match, or what we call a haplotransplant. We prefer, when we're looking for donor sources, to do the HLA identical sibling. They have the best outcome. If you don't have an HLA identical sibling, pretty much all these other transplant types, cord blood, haplotransplant, MUD, appear to have similar survival rates. In terms of unrelated donors, the registry has grown significantly worldwide, now more than 25 million donors. And this is the chances based on race of finding a perfectly matched donor, with these registries now spanning 52 countries. Cord blood, as I said before, is an off-the-shelf product that we can find a cord unit for the majority of adults that don't have a matched related or unrelated donor. And the advantage of these things is that you can just thaw them down and use them anytime. And they have a very low incidence of graft versus host disease. Haplotransplants are transplants that we use when we can't find a match-related donor or unrelated donor. Haplotransplants are half-match transplants. A patient's mother or father would, by definition, be a half-match, so they could be used. A patient's child would be a half-match by definition, so they could be used. And a patient's sibling would have a 50% chance, each sibling, of being a half-match. So we could virtually find a haplotransplant for every person that needs a transplant. These kind of transplants, the way we prevent the bad GVHD is after we give the chemotherapy and we infuse the haplocells, we wait about 3 days, and then on day 3 and 4, we give some chemotherapy to kill the T cells that normally would cause very severe GVHD. That prevents the GVHD. And the incidence of complications with these types of transplants related to GVHD are actually quite low. This is just some data showing that these haplotransplants, when compared to unrelated donor transplants, have very similar outcome using myeloablative conditioning or reduced intensity conditioning. This type of transplant now is being accepted as an alternative to match unrelated donor transplantation. And this is just some transplant trends to show you that over the last 40 years, there's been a real significant increase in the number of match unrelated donor transplants being done, now more than SIB transplants, because the registry is so large and families in the US are getting smaller, so the chances of finding an HLA identical sibling are actually decreasing. But what I wanted to show you here is that these haplotransplants, which were much less frequently used in any other transplant approach, began around 2015 being used more than cord transplants. And now they're actually tied for the number of transplants done compared to sibling transplants. And our expectation is that we in the very near future will see more haplotransplants done than HLA identical sibling transplants. So just wanted to conclude with saying that if you need a transplant, it's always important to answer the following questions to see if a transplant is truly something that would be beneficial for you. You always have to ask the question, does the potential benefit of the procedure outweigh the risks? So if you have a disease where chemotherapy can either cure you or make you live for a very long time, then it's unlikely that taking the risks associated with a transplant-related mortality would be worthwhile. On the other hand, if you have a disease where there's no good effective therapeutic, where the cancer can be lethal in short order, that's where a transplant may be potentially a better option. The other question is the disease sufficiently controlled to do a transplant? Timing is everything here. You have to have the disease in remission with leukemias to have better outcomes. So if somebody has leukemia that's relapsed and you get them into a CR2 with AML, that's a good time to take the transplant when there's no blasts, because the risk of relapse is much lower than if you were to wait till that patient relapsed again and transplanting them with blasts. Do you have a stem cell donor? The answer now is yes, pretty much for everyone, because we can do these cord transplants, these haplotransplants for people that don't have sibling donors and match unrelated donors. And then the last question is, what are the chances I could be harmed by the transplant? You have to make sure that the patient's healthy enough to go through the procedure, young enough to go through the procedure, and that they haven't received any treatments that might put them at increased risk for complications. For instance, if a patient had bad lung disease, maybe from prior chemotherapy or radiation, or maybe just from having some other underlying disease like COPD, then often the risk of these types of allotransplants can be much higher in that kind of population, where you may want to consider some other type of treatment modality where the risk is not justified under the context of the patient's underlying condition. So I'll stop there. Thank you, everyone, for your attention, and we will transition over to the question phase. Thank you.